Good morning. Thank you for joining us today. I'm glad to be here to talk with you about cognitive rehabilitation. Today's presentation has a lot of people on from a wide variety of backgrounds, and so I hope that I will be able to provide some information that will be helpful to each of you. It is 101, Cognitive Rehab 101, so a little bit of a kind of a basic overview. We're going to talk about what cognitive rehab is, who is the recipient of cognitive rehab, where cognitive rehab takes place, who the providers are, and then cover a little bit of information about some of the cognitive rehab strategies. And so just to begin, really we have to talk about cognition first. When you talk about cognitive rehab, of course, you have to understand what cognition is. Cognition is defined as the mental action or process of acquiring knowledge and understanding through thought and experience in the senses. It's the processes of knowing, including attending, remembering, and reasoning, and the content of the processes, things like concepts and memories. That's the American Psychological Association definition. And again, it encompasses knowledge and attention and memory, judgment, reasoning, comprehension, language. Without cognition, we can't use existing knowledge and generate new knowledge. These are internal mental processes that we can assess or test these with behavioral methods, but they're really not directly observable. The physical mechanisms of cognition involve the formation of connections between neurons in the brain and then the sending and receiving of signals between connected neurons. So then any factor that interferes with those processes create a barrier to cognition, and it's what we would refer to as a cognitive deficit. These are skills, cognitive skills, are skills that can be lost or can be altered due to brain damage that results from disease or injury. Cognitive functioning difficulties that are a result of disease or injury then often affect behavior and the ability to complete everyday tasks. And where other healthcare areas focus on prevention and treatment of disease, rehab broadly focuses on the enhancement of human functioning and the quality of life. There is, of course, a connection between disease or injury and that ability to function. As I said, sometimes or often a disease is cured, but a disability may remain, the disability that was created by or caused by the disease. At times, a disability can be reduced even in the presence of a disease or permanent injury. Many people think of rehab as concerning improving only physical disabilities, but of course rehab's not really limited to that at all. Cognitive rehab attempts to enhance functioning and independence in adults with cognitive deficits or impairments, again, that are the result of brain damage or disease, things that really commonly follow injuries like traumatic brain injuries or stroke. So let's see, let me go on to one of the definitions of cognitive rehab, and there are many for a number of reasons that I'll talk about too. But the Brain Injury Interdisciplinary Special Interest Group, which is part of the American Congress of Rehabilitation Medicine, has the most commonly referenced definition, and it is interdisciplinary. It's a systematic, functionally oriented service of therapeutic cognitive activities based on an assessment and an understanding of the person's brain behavior deficits. This is a definition that really allows for comprehensive interdisciplinary rehab programs with interventions to restore or reorganize function, to compensate for impaired function through new cognitive patterns or external devices, and to enable individuals to adapt to their new level of functioning. So cognitive rehab therapies may target specific cognitive domains like attention and reasoning and planning and memory, like we're going to talk about, and it is delivered in various contexts that we'll also talk some about. This is the definition according to one large insurance company, and I put this in here not because we are going to talk about insurance or reimbursement, but just to point out that insurance and the healthcare system really does kind of drive a great deal of the variables around the delivery of cognitive rehab in the United States. And so for providers of cognitive rehab, it's always important to make sure that you know what the requirements are, and that would include the various definitions. And the point that I want to make here is that this insurance company's definition requires these things. So all of the following here, all of the following are met. Number 2, the cognitive deficits have been acquired as a result of neurologic impairment due to moderate to severe traumatic brain injury, brain surgery, stroke, or encephalopathy, of course, other conditions. But the point that I want to make about this is that Aetna, I'm sorry, I was going to not tell you which large insurance company that was. This insurance company considers cognitive rehab experimental. Many do, actually, not just this one. For other indications other than those that are the result of a traumatic brain injury, surgery, stroke, or encephalopathy. So for treatment of things like seizure disorders, learning disabilities, cerebral palsy, memory deficits that are due to other kinds of things, it is not indicated at all by many insurance companies. So we're kind of going to stick today to the definition that would encompass those major causes of brain injury. And first, a little bit of information about the history of cognitive rehab. It's pretty much, the field of cognitive rehab has developed alongside wars, at least in the early stages. World War I and post-World War I, advocates for soldiers with head injuries really did feel that they could be rehabilitated. There was some different opinion about the strategy to be used, with some recommending remediation and others recommending direct vocational training, which was, of course, largely the focus of rehab, both World War I and World War II. It was the return to work idea. Post-World War I, there was the introduction of functional skill building for injured veterans, and there were actually some schools for soldiers that were considered rehab hospitals, especially in Germany. There were some German rehab hospitals, and they involved psych testing and measurement of concrete skills. They really did not emphasize things like attention and concentration and memory training like we do today. In the United States, there really was not much attention to this area at that time. There was one hospital in New Jersey in Cape May, the Hospital for Head Surgeries, and they provided some incidental rehab, mostly by involving patients in doing everyday tasks around the hospital, but not directly training in cognitive rehab. During World War II, there was an increase in the interest in cognitive rehab, and in England, there were brain injury centers that were opened in Oxford and Edinburgh after World War II. Neuropsychologist Oliver Zangwill, who later founded INS, developed an approach that utilized mostly skill-specific training and then also focused on training for specific abilities in certain conditions. He really thought neuropsych tests were helpful for detecting non-obvious impairment, but not as helpful for predicting vocational or school outcome. He thought it was better to use neurobehavioral task analysis for these purposes. And then post-World War II, there was the continued use of rehab strategies in multiple countries. It began to spread, again, largely around the treatment of soldiers with brain injuries. In Russia, Alexander Luria's work rehabilitating soldiers on a neurosurgical unit in the Ural Mountains led to the development of the theory of functional systems. He assessed neurocognitive functioning and the use of various adaptive mechanisms, and then identified the patient's spared skills that could be used to avert deficits and help build strengths. He proposed 3 functional units in the brain that had to work in concert with each other for normal cognitive functioning. And then, that's really kind of where that integrated view of brain functioning that we have today came from, rather than just focusing on localization. And Luria developed this 2-pronged strategy of cognitive rehab. Actually, we're going to talk a little bit more about that in a bit. But the goal at that point was, with Luria, was to strengthen spared skills and teach compensatory skills, and that is still used today. That's one of the the focuses, or one of the areas of focus today. In the U.S., cognitive rehab at that time began to occur under the guise of nervous and mental re-education. It was really developing out of psychiatric influences that were growing at the time as well. But psychologists and speech-language pathologists were spearheading treatment at that time. And then after World War II, that kind of work really did slow down again considerably. Today, of course, we're doing a great deal of work with patients who've had head injuries and blast injuries, and we're learning that the brain doesn't even actually have to be struck to experience an injury. Since the 70s, there's been a big increased attention in the United States to head injuries from things like car accidents and sports injuries, more in the last couple of decades. We're learning more about trauma in general, increasing our attention to prevention and education efforts. If you look at what's going on in car manufacturing, just the kinds of adaptations and features that are available in cars, and with the coming, and I guess already here, self-driving cars, this has created a lot more awareness about the impact of injuries. Sports and recreational head injuries, of course, have been there's been a tremendous increase in looking at those and the impact of those. The first acute rehab programs in the U.S. just for head injuries were in 1975, and growth has really continued tremendously since that time. Differences across the definitions of cognitive rehab and cognitive rehab therapies are based on theoretical differences regarding the underlying cognitive mechanisms that result in behavioral changes. The Brain Injury Association of America, which is the largest U.S. advocacy organization for individuals with brain injury, points out that these theoretical models vary along several different dimensions, some of them being the treatments. Treatments may be process-specific or focused on improving a particular cognitive domain or aimed at improving performance of particular activities. Sometimes the overall goal is to restore function in a cognitive domain or a set of domains, or in other times it's to teach those compensatory strategies. And so a range of therapies have been developed. Most U.S. cognitive rehab has been based on models of physical rehab, first begun around the treatment of polio, with the theory being that if the muscle's weak, you exercise it, it gets stronger. So if the brain is exercised, it's going to grow and develop like a muscle. But that's really kind of an inadequate assumption for brain cells. Brain injury results in neuronal cell damage, and that means that those cells are permanently damaged or gone, permanently affecting their previous function and associated dysfunction, and that compromises overall brain integrity and affects basic information processing and higher cognitive functions, especially executive functions. So unless other healthy cells in the region can be trained to take over the function of these damaged cells, the cells that are damaged in in brain injury, if they are killed, they do not regenerate. If those brain cells die, they don't regenerate. So the idea of cognitive remediation comes from the word remedy, which means to cure. That sometimes gives people kind of the idea that cognitive rehab can cure brain damage. But what we know about brain cells is that they're really different than skin cells or muscle cells, and they don't regenerate like other cells in the body if they have died. So we talk about cognitive rehab or retraining instead of remediation. Let's see, cognitive psychology. It was during the 70s and 80s that rehab researchers and therapists really became interested in cognitive psychology here in the States, and cognitive psychology had gone through a period of rapid growth in the 60s, and it was greatly impacted by the study of neurocognition and the treatment of cognitive impairments, and so new rehab techniques began to be studied to address cognitive impairment at that time. Another consideration is that a lot of the theories behind interventions are driven by deficits. So they're focused on improvement of specific isolated cognitive deficits without really understanding how that deficit could improve. So, more than thinking about just things like exercise theory, we have to also consider compensation theories. that what we're really doing is training the remaining intact neural pathways to take over the function of some of the damaged pathways in order to improve the function of the cells and in everyday life. Repetition alone doesn't bring back dead cells or make living brain cells do what the dead brain cells did. So there has to be a theoretical framework for kind of understanding how information processing and executive functioning and things like that can improve. There are some noteworthy barriers to or difficulties with research in this area, namely just the complexity of the brain, the individuality of brain development, brain function, and then of course the individuality of any brain injury. And then there's some methodological difficulties as well that we don't have time to talk about today, but just things like the difference in types of studies and research designs, and it's difficult to design a research study with matched control and experimental groups when you're considering brain functioning. In the past, though, the prognosis for recovery after brain injury really wasn't all that great. There just wasn't very much understanding of the brain's ability to recover. There was little expectation that patients would recover full function, and little understanding or practice of cognitive rehab strategies. And patients were kind of on their own largely, and recovery was left to chance. But we really have learned a lot. We understand much more about the brain's ability to recover. Cognitive rehab has become much more common, and patient outcomes have improved significantly. So looking at some of the cognitive deficits, the causes of cognitive deficits, I'm going to focus just a little bit on causes that are lasting, brain injury, stroke and TBI, and neurological disorders. And we're going to talk just briefly about those, not much at all about the temporary causes. So cognitive deficits themselves usually affect specific cognitive functions. You can see some of those here. About 80% of people with deficits due to stroke and TBI will also have an attention deficit or will have an attention deficit. About 65% will have a memory deficit. About 75% will have executive function deficits. But most of you probably know that attention, memory, and executive function are the most common cognitive deficits, no matter the cause. If you look at the functional areas of the brain, this is a little bit of a simplistic view, I know, but it is kind of an easy to understand one. The brain is not quite that simple at all. But each of the cognitive functions is associated with a particular area of the brain. That is not to say that it's confined to that area, but it's associated. So here you can see, if you look at, for example, the frontal lobe, you've got thinking and planning and problem solving and decision making, which we refer to as executive function, largely. This area is also responsible for impulse control or response inhibition, as it's often known. The temporal lobe is where you will find, not all of, but a lot of memory and speech, hearing, facial recognition. In the occipital lobe, the rear of the brain, there's vision, the processing of visual information. The parietal lobe controls perception, classification of objects, spelling, number recognition, visual spatial processing. What I haven't shown you here is where attention is, and that is because it's pretty much everywhere. If you were to mark up the attention areas of the brain, it would be in all of those lobes. The same functional areas are found in the right hemisphere, even though I'm just showing from the left side here. Generally speaking, both hemispheres perform the same cognitive functions, and they usually share the workload. There is sometimes some specialization on particular tasks. Again, there's a lot of different diagrams of the functional areas of the brain that you can find. And really, if you wanted a more realistic diagram, it would look more like this, with each area of the brain that talking back and forth with multiple other areas to perform a single function. If you tried to follow one of those, you would have to untangle it all over the brain. It quickly becomes so complex that it's really difficult to talk about it like that, which is why people use a more simplified model to show the brain. So back to the causes of cognitive deficits quickly, just looking at stroke first. A stroke is defined as the sudden damage or death of brain cells due to a lack of oxygen, which is caused by either a blockage of blood flow or the rupture of an artery to the brain. There's two types of strokes. Like I just described, one is when the blood flow is blocked, and that's called an ischemic stroke, and it really depends on the location of the blockage, the damage does.